So as we're getting closer to our registered attendees, I'm glad this is happening. I don't know how many of you had Zoom issues this morning, but it seems there was a little issue with Cloudflare doing an update that knocked out some servers. And I always feel bad for that engineer or that team lead that has to deal with millions of people not being able to connect to the internet or their preferred choice of virtual tools. But with that, it is 1:03 on the East Coast. I know we have some more people that will be joining us, but I do want to be respectful of not only your time, but also allowing for the great conversation to happen with our panelists. So with that, my name is Katie Vlietstra-Wanenberg. I'm a principal, co-founder of Public-Private Strategies. And this is the third in a series of 4 of discussions related to the implications of the midterm election on tax policy. Just so you guys all know, we are recording this because we are hopeful that we'll be able to disseminate this wide and help people as they're thinking about how they're going to engage with lawmakers and policymakers post midterm, as organizations are really starting to strategize as to what are the implications for divided government as it relates to some very key issues within our tax code. So I just want to share that the other reason why we're recording these is, as I mentioned, this is the third in a series of 4. We've had 2 fantastic conversations, one around family policy and then the other about employment. And so as we continue our series, we are going to be able to put together a compilation of all 4 to share. But one of the reasons why we came together with our great partners at Niskanen to facilitate this webinar series is because I think that as we are looking towards the midterm elections and the implications that we'll have on policy, how can we, as a community that are very interested in these issues, come together, I think, have open and honest and tough conversations about how tax policy is used to lift up family policy, if it's employment, and now today we'll be talking about healthcare. And I think really support the work that's being done within the philanthropic donor community to think about how they are positioning themselves in light of what we most likely will be at least a Republican House, potentially some changes with our Senate, but also with the 2 years of the Biden-Harris administration. So I do want to thank our friends at Niskanen. I know Sam will come in at the end and do our closing. It was really a brainchild of his and Lee Gibson that we put together this series. We are just been so grateful to partner and collaborate with them. I also just want to thank the Rockefeller Foundation for supporting this work and really, I think, pushing all of us to have not multi-sector, industry across the political spectrum, these conversations as it relates to things that we're all really passionate about. And I want to thank the panelists that we've had on our first 2 panels, and of course, thank those who are able to join us. And with that, I do want to turn it over to Ariel Kane, a director of healthcare at the Progressive Policy Institute, who's going to be our moderator today to introduce our panel and kick us off. So with that, Ariel, I will turn it over to you.
Thanks, Katie. I'm excited to be here today. As Katie said, I'm the Director of Healthcare Policy at the Progressive Policy Institute, and I'm here to moderate a discussion around what advocates and stakeholders can expect in an era of divided government. Given that so much of the national conversation has been around Biden's agenda with the Democratic majority and how the Democrats are responding to his agenda, we wanted to devote some time to exploring how people should prepare if Republicans control either the House or the Senate or both during the second half of his term. And to spearhead that conversation, I have 3 healthcare policy experts here today. First, we have Robert Orr, who is a social policy analyst at the Niskanen Center. His research focuses on social insurance policy issues, healthcare, and labor market issues, and he previously worked at the Cato Institute. Next, we have Avik Roy. He is the founder and president of the Foundation for Research on Equal Opportunity, FREOP, a nonpartisan, nonprofit think tank that conducts original research on expanding opportunity to those who need it most. And finally, we have Christopher Pope, a senior fellow at the Manhattan Institute. Previously, he was director of policy at West Health, a nonprofit medical research organization, and a health policy fellow on the Energy and Commerce Committee. So with those introductions out of the way, we're just going to go ahead and jump right in. To open our discussion, I wanted to ask everyone, so this is a group question, about what the current state of play is in healthcare policy. We're 12 years into the ACA, and it seems like Republicans are no longer pushing for repeal, but it also seems like Democrats haven't coalesced around what should come next. So, where do we stand? Ovik, do you want to take the first stab at that question?
Well, I don't think there's a definite place where everybody stands, right? There's a number of different schools of thought. If you go from left to right, there's obviously the Medicare for all, quote unquote, or single payer group. There's the Let's Build on Obamacare group, which the president would probably identify with. Then, going right of center, there are different groups as well. There's really a group that doesn't think about healthcare, frankly, at all. And on the Republican side, particularly members of Congress who are sort of traumatized by their last attempt to do something in healthcare and are kind of afraid of it. And then there's another group that is very concerned about rising healthcare costs and is open to a lot of new ideas on how to tackle the cost of healthcare. So I think what you're seeing on the Republican side is a lot of interest in tackling the cost of healthcare, but I wouldn't say there's necessarily a consensus on how to do that. Some people are more willing to use tools like antitrust and pro-competition kind of ideas to create more price competition, therefore lower costs. Others are more worried about what trade associations might say about lowering their costs and are worried about that pushback. So a bunch of different points of view out there. I think the one thing that is very clear is that the President Trump, when he was in office, he really initiated a lot of these. He stirred the drink, in that particularly his aggressive goals on drug pricing reform led a lot of Republicans to rethink their long-held positions on prescription drug pricing status quo. I think that's in particular an area where there may be an opportunity for Democrats and Republicans to work together.
Great. That's a great point, and you brought up my most personal favorite topic, which is healthcare costs. Robert, do you want to take a stab at the same question?
Sure. Yeah. So over the sort of immediate term, the main question is whether they're going to, the Democrats are going to get ACA subsidies extended. And as far as the immediate horizon, that's the question. And sort of we're trying to figure out what's going to happen after that. And as Ovik mentioned, there's a lot of disagreement sort of what within both parties on sort of what that future direction will look like. But I'll add that there's a good deal of action that is going on at the state level as well. States are interested in things like postpartum Medicaid extension, and there's lots of changes to scope of practice and other sorts of healthcare things. So a lot's going on, but at the federal level, it's not exactly clear where things are headed.
And Chris, any opening thoughts?
Yeah, I always think of healthcare spending as a big pie defined by the spending numbers. So if you think of healthcare as a $3 trillion a year industry, probably 90, maybe 95% of that is on autopilot in some ways. If Congress doesn't touch Medicare, Medicare will do its thing. So will Medicaid, so will employer-sponsored insurance. As Robert said, the one area that isn't necessarily on autopilot right now is the individual market, and especially the tax credit issue. And so what happens in the next Congress, I think, is going to be very much shaped on what manages to get done in this Congress, the subsidies. I think if you kind of look at the magnitude of the subsidies for individual market plans relative to the tax subsidy for employer-sponsored insurance, the proposed increase would really take the individual market way out of whack compared to employer-sponsored insurance, any other kind of healthcare in terms of subsidies, and that would create some real equity challenges and some real kind of strain on the employer firewall. So I think if BBB does or bump up the subsidies or retain the bump from ARPA into the next year, that's going to be something the Republicans are definitely going to want to look at, especially not because the individual market is necessarily so huge, but because the individual market is something that everyone has designs for. People want the individual market to be a functioning market, even if it's fairly small right now. It is something that sort of people want to build around, and having that not be completely swamped by subsidies that make it unresponsive to cost is an important policy objective. So I think if there's no action on BBB and ARPA, no reauthorization, maybe that becomes an area where autopilot it prevails and things go on without too much change. But I think if the subsidies are bumped in this Congress, it's going to be an easy thing for a Republican Congress to kind of look at again, think, well, does this make sense? There's some more money on the table. How does this market work? And that will immediately become a target, I think, in the next Congress.
That's a really good point, that as someone who looks at things from a Democratic lens, I hadn't considered about, sort of the positioning of Republicans in the next Congress. When we think about, an era of divided government and outside stakeholders who are interested in their own priorities, how should they be positioning themselves or preparing themselves to be effective in an era of divided government? Does someone want to take the first stab at that one?
Well, I'd say that, as I mentioned, there's opportunities to be had. I think that the cost area is the one where the opportunities are the greatest, right? I think that if we just look at if we observe what we've seen, a lot of the Biden approach to healthcare has been, let's spend more money, right? Subsidize healthcare more. That's the way we're going to address these gaps for people for whom their healthcare bills are too high. And yet, the paradox is part of why healthcare is so expensive is because of the way we subsidize it, particularly in the employer market, which I know is a core element of our call today. The tax solution for employer-sponsored health insurance is a $300 to $400 billion a year subsidy of health insurance, which has driven a lot of the healthcare inflation that we've had for the last 80 years. It's a big part of why our healthcare system is more expensive than any other system in the world. And so can that be changed? If anything, there's been bipartisan majorities to preserve and ossify the employer tax exclusion rather than to reform it in recent years. The ACA, of course, tried to do something about that with the Cadillac tax. So the question is, can we move to a system instead of just saying healthcare is getting more expensive, so we're just going to subsidize it more? That's been one default orientation of many members of Congress. Can we reorient ourselves another way where we say, actually, the real thing we need to do is reduce the underlying cost of healthcare and have a real conversation about what the tools are in the toolbox to reduce the underlying cost of healthcare?
Anyone else want to weigh in on that topic or build on Ovik's point?
Sure. Sort of one opportunity for philanthropy is to sort of zoom in on more discrete issues and less on the sort of big systemic change that a lot of the policy making discourse is focused on. Sort of both parties are internally cross-pressured by members who are basically aligned more with maybe doctors versus insurers versus hospitals versus nurses. And it's easier to cobble together a coalition that can focus on this discrete issue if you're willing to sort of draw from both sides and focus specifically.
Are you thinking of any specific issues, like when you're talking about that strategy?
Sure. So in the recent Republican task force on healthcare reform, one of the suggestions was to reclassify insulin treatment as preventative care. That's something that, you know, if you just sort of focused energies on sort of that discrete problem rather than tying it to a whole bunch of other things, it's easier to get these sort of incremental change passed.
That's a great point. Chris, do you want to talk about this, or I have another question for you if you're ready to move on? Okay, you're on mute though, so unmute
Sorry, go with the
yourself.
next question. Yeah.
Okay, so building on the topic of healthcare costs and your point about the autopilot, you know, you recently wrote about the twilight of social insurance and how there's a looming expiration of the Medicare Trust Fund. And, you know, Congress at some point needs to do something about it. And how do you think philanthropy advocates and Congress should talk about this issue?
Well, I think Medicare, I mean, I think the point of that article was really to make the point that Medicare isn't really social insurance. It's not an attempt to give people a benefit in proportion to their prior contributions. It's an attempt to fill in a gap that private markets were unable to provide. The fact that by the 1950s, early 1960s, the employer-sponsored insurance is doing well, had covered the vast majority of the working population, but seniors were really without health insurance coverage. And it was really just a pragmatic attempt to fill in that gap. And I think going forward, I think that's sort of the way we should be thinking about Medicare as well. I mean, it isn't an elaborate kind of attempt to sort of balance funds over a long term. We should really be thinking about the program in pragmatic terms, like, is this good value for money? How does it do what people can't do for themselves? Is it empowering seniors to basically get the best value care? And ultimately, is it good value for taxpayers? Now, the issue of the trust fund is both a distraction and not a distraction. It's a distraction in the sense that I think it makes a little sense to pay for this program, or at least Part A, through payroll taxes. I don't think there's any real case for such a regressive funding source. But secondarily, I think it makes sense to have the program. You have a good conversation about Medicare, and we've had a good conversation about Medicare, and we've reformed Medicare the most over the past 40 years, when people have looked at Medicare alongside other budget items. And they thought, well, Medicare is growing on autopilot. We're talking about hundreds of billions of dollars every year. And yet there are other federal budget items, there are other federal budget priorities that are more worthy. And when we've had a reform of Medicare in the past, throughout the 1980s with prospective payment, throughout the 90s with all kinds of different payment reforms, it's largely been motivated by a desire to share savings from the program. For Medicaid, Democrats have used most Medicaid expansions have been funded through cuts to Medicare, and also paying down the deficit and paying for tax cuts. So the general way to think about Medicare policy, I think, is to move away from the notion that it's kind of dependent on a sacrosanct system of funding or mathematics. It's really part of the federal budget and ought to be thought of that way. It's enormously costly and rightly so in many ways. But we shouldn't be dogmatic about these funds are for Medicare, these funds are for other things, because the money all comes from the same place ultimately.
That's a great point. And I think is an interesting counterpoint to Robert's point about discrete issues versus like large, big fundamental questions about funding these programs. So Robert, I'm going to circle back to you. You've written a lot about the shortage of medical providers and doctors, and you mentioned things that are happening on the state level. So what actions are happening that could increase the supply of healthcare providers? What could Congress do? And how, do you think this is an area where we can make progress in an era of divided government?
Sure. Yeah. So on the state level, there's been a lot of progress, especially since the pandemic, in terms of expanding practice authority for nurses, physician's assistants, other sorts of healthcare professionals along different margins, allowing pharmacists to be more active, things as such. And I think that that's probably going to continue. It seems like in the view of many, the advocates of increased scope of practice have sort of won the day, and you're seeing it even in states that have traditionally held out, such as New York. In terms of what Congress can do, they could reform the way that we finance residencies to make sure that we're distributing them better, more equally throughout the country. Making sure that we're prioritizing the funding at the beginning of the residency, which is when residents are likely to be net losses to hospitals, sort of just spending the money more efficiently and making it so that we're getting the doctors where we need them. Stepping back, something that the United States should really sort of get involved more in is alternative ways of training healthcare professions. So lots of countries are using these sort of degree apprenticeship programs that allow someone to become a nurse and sort of get a BA equivalent while working the entire time. And that would be a huge benefit in terms of addressing supply, especially given how expensive education is in the US.
We got a question while you were talking about, is there any appetite for this? So either, increasing the number of visas for physicians. We know that, when COVID hit and it became a lot harder to bring, trained doctors into this country. Is there any appetite for changing those things or any other sort of changes to the residency program?
Here, yes, there is exactly what that looks like. There's lots of different opinions, but various congresspersons have put out legislation on that front.
That's great. Well, that brings me to my next question, sort of on the Republican front. Ovik, you've worked with Senator Romney in the past, and he recently released the Family Security Act 2.0, which includes an expansion to the child tax credit and would allow parents to receive the child tax credit for up to 4 months prior to the birth of their child. How does this and other sort of Republican ideas set the stage for a new Congress in January 2023?
You mean in the healthcare context or more generally?
Or just, I think more generally, like, are we going to see, sign of collaboration with the Biden administration? Are there areas for agreement? Kind of what's the tenor going to be with Republicans in Congress?
Yeah, if we look at historical patterns, and I think that there's no reason to believe that things would diverge from historical patterns in this particular sense, is that when we've had Democratic presidents and we've had at least one branch of the legislature controlled by Republicans, a big focus of or a big kind of limit or ceiling has been spending. So I think you're going to see a lot of resistance from, say, a Republican House to efforts that are a step change increase in spending, federal spending. Now, the virtue of the Romney, the bill that you're bringing up in terms of child tax credits is that it is funded mostly by reallocating money from existing welfare programs, though there are some tax-based elements to how the bill is funded. So that's an example of something where there was a fair amount of effort to try to say, okay, let's take existing welfare programs and reform them, such as the earned income tax credit in order to fund a child tax credit. So there are some elements like that. There's some elements of quasi work requirements where the value of the child tax credit is diminished if you earn less than $10,000. The idea being if you earn $10,000 or more, that's effectively a form of a work requirement, because in order to earn those $10,000, you need to be working at some level. So there's some interesting ideas in the Romney bill that I think get to some of the things that Republicans are interested in, such as work requirements. I would say that a question that in terms of bringing it back to healthcare, work requirements are something you hear a lot of Republicans talk about. For example, you hear a lot of Republicans say things like, well, in order to expand Medicaid in a given state, there should be a work requirement associated with that. Now, the Medicaid law, Title 19 of the Social Security Act, does not really allow for work requirements, at least as conventionally designed. There was obviously some effort to try to develop that during the Trump administration years. And more broadly speaking, it's not clear whether there's value, in my view, in work requirements in the healthcare context, because people need access to affordable healthcare regardless of whether they have a job or not. We certainly don't want to create disincentives to work, but the bigger problem when it comes to the relationship between employment and healthcare is the fact that so many people feel the need to be at a job where they're provided with employer-sponsored health insurance in order to get access to affordable coverage. And so I think what's going to be interesting to see as we move further and further away from the passage of the ACA in 2010 is do we start to see more Republicans say, hey, instead of ignoring the individual market for health insurance, the market in which people buy insurance on their own through things like healthcare.gov, that's something that in the post-Obamacare era, Republicans have not wanted to touch. They've not wanted to make it better, because to make it better means to improve Obamacare. And that's been a sort of kind of a box that Republicans have put them in. And what I'm going to be interested to see in the healthcare context is whether or not Republicans are willing to move on from that. I think many are, but I think it remains to be seen how many are. I think the more that Democrats and Republicans can work together to improve the individual market, not merely by throwing money at it, but actually by reforming the design of the individual market so it functions better, I think that could be very interesting.
I would really second what Vic's saying there.
So my internet is being.
Well, I see what Vic's saying. Just carry on.
Go ahead, Chris. I can hear you.
I think that is the big question: is are we really past all the personal branding of Obamacare? Are people so far past 2010? And I think there's a real sense that is the case. I don't know if it's exactly the majority of Congress that weren't there in 2010, but it's surely pretty close to it. And so people don't have a paper trail. A lot of these incoming members, certainly after November, will quite likely have never really talked about healthcare in any real in-depth sense. It won't have been an issue on which they have a paper trail to defend, a whole host of remarks that are more categorical than they like. And so there might be more wiggle room. Now, the question is, how much would the Biden administration itself be willing to compromise some of the regulations at the heart of the Affordable Care Act? How much might it be able to be willing to back down from community rating or allow some forms of underwriting that really fix the market, given the realizations that the subsidies are more important than some of these rating rules to protecting individuals with pre-existing conditions. And I think that's going to take a bit of a dialogue. Now, the question is, what appetite is there on both sides to engage in what is, frankly, a fairly technical dialogue? If both parties agree, or experts in both parties agree, that there are rating rules that need tweaking and they can provide some extra money or move money around to make that reform happen, it need not become a hugely controversial thing. But it is going to require some leadership and some people getting together from both parties to shepherd it through, and that's probably going to come down to an issue of relationships, and it's hard to say without knowing the people involved specifically.
Thank you, Chris. Hi, everyone. My name is Michael Vasquez. While Ariel's internet or technical issues are being worked out, I'm just going to jump in and help us keep moving along. So I think the question we want to build up from there then is how can, for all of y'all, feel free to jump in, is how can the philanthropic community begin engaging at this stage, right? So we head into this new reality, like what would you recommend philanthropic community as well as advocates more broadly do to engage with changing government?
Well, one area where there's a couple things that philanthropists can do to use that specific example. One area where I think there's been perhaps an underappreciated element of philanthropic activity is in actually participating in the market to try to disrupt some of the cozy monopoly type relations that we've had. For example, a number of nonprofits banded together to form Civica RX, effectively a kind of a pharmaceutical / pharmacy effort to compete where generic drugs are largely absent for various reasons. There's a for-profit company called EQRX, which is basically trying to develop drugs that are branded but are effectively clinically comparable and chemically comparable to existing drugs in ways that create competition where there isn't any. So one area where both venture philanthropy and traditional philanthropy can make an impact is on those kinds of businesses that create competition or helps support competition where it's absent, whether it's in pharmaceuticals or in hospital or physician monopoly areas. That's one element. And obviously, if a philanthropist can support, if to the degree that people are interested in the public policy side of it, there's obviously a lot of places that would be grateful for philanthropic support where you think that they have ideas that would advance. Particularly, again, I think this idea of competition and reducing costs. There's a lot of consensus on the left and right about the fact that healthcare in America is too expensive. There's obviously a lot of debate about how exactly to go about reducing those costs, but I think there's a lot of it's actually in a sense underfunded. Thinking about what are some of the ideas that can generate bipartisan credibility on lowering costs. So I think that's an area where there is actually, relative to where healthcare oriented philanthropy is, that's an area that's relatively speaking less allocated to, I would argue.
Thank you. Looks like Ariel's back, so we're just on the question of.
I'm so sorry, my internet just kicked me off, and it took me like 5 minutes to get it to work. But so I'm sorry I missed what you were saying, because now I might repeat questions. But I wanted to talk a little bit more about, kind of the Republican angle of healthcare policy, given the climate that we're currently in. Robert, I'm coming back to you. My question specifically is, there has been some movement in maternal health. You mentioned, or maybe you wrote about, states like Georgia that have expanded Medicaid for postpartum women, even when they're not expanding Medicaid throughout the state. And, what is that going to look like in a world, a post Roe v. Wade world? Like, is that going to be more contentious where you see Democrats unwilling to be compromising because, they see it as being hypocritical or something? If you're not willing to support access to abortion, then why would you help women in another capacity? I don't know. I'm just wondering, what is it going to be more politicized in a post Roe v. Wade world, or is it still going to be an area where you might see some consensus?
I tend to think it's going to be an area of consensus, just because the out-of-pocket costs for maternal care are quite high, even if you've got insurance, and it's something that people, across the political spectrum in both parties can relate to. Just the sticker shock associated with having a child, and so I don't expect. We've seen expansions in both red and blue states, and under Republican and Democratic governors, and so I don't expect that to be particularly contentious. I would see that as an area where you're likely to see bipartisan sort of compromise. Whether that sort of leads to sort of broader rethinks around maternal care with regard to maybe private insurance or whatever, that's an open question.
Thanks for that. And does anyone else have any sort of thoughts on that issue of just like how things might play out given, you know, just a lot of animosity between Democrats and Republicans on, you know, specifically on healthcare, but on other issues as well? And does that compromise Congress or state legislatures' ability to move forward on other issues?
Just to give an example of a kind of contrary point, there's a bill that's been sponsored by a couple of a half dozen Republicans called the Fair Care Act that we've been somewhat involved with as well at FreeOp, that strives to achieve universal coverage by improving and refining the ways in which private insurance work in the U.S., whether it's ACA sponsored insurance or employer sponsored insurance or Medicare Advantage. And that's a bill that has a lot of stuff in it that either philosophically should appeal to Democrats or actually comes from Democratic bills as well. So there are people out there who are working on stuff that in an ideal world would appeal to both Democrats and Republicans. And the reason why Democrats have so far not paid attention to it is because there's been in this internal debate on the Democratic side about, are we for a public option or are we for Medicare for all? And really no room to do anything other than those two choices. So I think there's a real opportunity here if, say, you know, Democratic policy entrepreneurs who say, okay, if we want to do things in a bipartisan way, we have to leave aside the public option and Medicare for all, because obviously no Republican is going to support those things, or certainly very few. But are there other things besides a public option and Medicare for all that could be opportunities for bipartisan legislation? And again, I would argue that there are, and it's not merely a theoretical thing. There are bills that have been introduced in Congress that merit some attention. I'll give one example. So there's a bill called the Hospital Competition Act that was proposed by Jim Banks, who's the head of the Republican Study Committee. So the major Republican or the conservative caucus in the House, that's really the engine of a lot of public policy that comes out of the Republican side of the House. He is the chairman of that caucus, and he's put out a bill called the Hospital Competition Act that would leverage both antitrust by actually increasing funding for the Federal Trade Commission, but also use some other tools to really drive much more hospital competition, and where there are hospital monopolies just charging whatever they want to charge, holding them much more accountable for the disparity between the prices they charge people with private insurance and what they charge people with public insurance. So that's an example of an idea that one could easily imagine a lot of Democrats taking on and finding very interesting if they can move off the public option or Medicare for all or nothing set of choices.
Yeah, I have definitely, as a, you know, someone who's approaching healthcare from a more left-leaning perspective, I myself have been frustrated with how Democrats have positioned themselves because we don't have the votes for Medicare for all. So why do we devote so much energy to talking about it? And then, you know, there's just other ways to be creative and innovative and to make a real difference in people's lives, you know, and like I said, Vic, you know, healthcare costs is what I think would make the most difference in people's lives. That's why people don't have insurance, is because it costs too much. And so, but I wanted to actually go back. You were talking about the bill that you've been working on, Fair Care. Say it again.
Yeah, it's called the Fair Care Act. I can put a link in the chat to a right above it so people who are interested can take a look at it.
Yeah.
The co-sponsor in the House is Bruce Westerman of Arkansas, and the lead sponsor in the Senate is Mike Braun of Indiana. And the bill, it's a broad-based health reform bill. So it looks at a lot of different elements of the healthcare system. It reforms and improves the individual market, in particular by funding reinsurance, so that it's effectively a kind of invisible high-risk pool that allows the sickest people to get more subsidies for their healthcare than they do today, which paradoxically, or not paradoxically for those of us who do healthcare for a living, makes actually healthcare less expensive also for healthy people, because you're not requiring healthy people to cross-subsidize the sick people as much. So that can improve the individual market. It reforms the employer-sponsored market to give employers more ability to, instead of sponsoring group insurance themselves, take the tax benefit and give it to the worker to choose his or her own insurance on the individual market. It does a bunch of things around Medicaid reform to increase the fluidity between people who participate in the ACA exchanges and people who are just below the poverty level who are not eligible for the ACA exchanges. It tackles drug pricing and hospital costs. And it does some other things to improve how Medicare Advantage works too. So it's a pretty broad-based bill, has a lot in it, and I'll send this write-up that explains a lot of that. But again, someone doesn't have to agree with every single thing in it from a Democratic point of view, but there's plenty in there that Democrats who've been involved in healthcare for a long time will look at and say, hey, that's something that I can support, and again can provide at least a basis for an engagement between the two parties.
Well, Chris, that's what I wanted to kind of turn to you about that idea. So the bill that Ovik is talking about and sort of, kind of reforming many parts of the market, but in particular the individual market, how would you see that playing out, if we have this increase in subsidies or if we don't, sort of thinking in the two universes that you laid out at the beginning of this conversation?
Well, I appreciate the question. I have a report about to come out on really how to align better the implicit tax subsidies for the individual market and the employer market. Because we should really, from a public policy perspective, we're trying to get people healthcare. We're trying to get people cost-effective healthcare. And we really want whatever's the most effective, whether it's through the employer or the individual purchasing themselves. I think there are good reasons to presume, and I think maybe some other people on this call share this presumption, that if an individual is choosing their own package, their own insurance, their own benefits, it's going to be more suited to their needs than if their HR department's trying to pick for them and another 100 people. But from a policy perspective, you definitely don't have things biased too much one direction or the other. And so for the higher income earners, policy is pretty much biased towards employer-sponsored coverage. For the lower earners, with the ACA, we have a tax bias towards the individual market, but we also have a provision known as the employer firewall, which means if you're a low earner with an offer of employer-sponsored coverage, you're not allowed to go and claim those individual subsidies. And then in ARPA, those individual market subsidies were greatly increased. So we have this kind of chaotic patchwork that's been created over time, and quite understandably so, really bit by bit to fill in different gaps. And then in many ways, that's a very reasonable way to think of policy, but up to a certain extent. And I think we've sort of gotten to a point where we have a chaos of different subsidy packages that are at war with each other, and they're not really coordinated, and they're not really pushing in the same direction. And people are stuck in plans that are not great for them. If you think of the pre-existing condition problem, what is that mostly in practice? Well, for the most part, it's someone who had a job, then they leave the job, and it's at the moment that they leave the job that their pre-existing condition is a problem. So long as you're within a job, your condition is just a condition. You're sicker or healthier as time goes on, but you're not disallowed coverage. And if you're on the individual market for a long extended period of time, you would keep your coverage. You would sign up before you get sick and potentially stay in there for many years and not be disqualified because you would have a guarantee for renewability. And so it's the incoherence of the markets that are the real source of so many of our problems. The lack of accountability, the gaps in coverage, the uninsured, people being denied coverage from pre-existing conditions, is because people are really trying to make what's a very perilous leap right now from the island of employer-sponsored coverage to the island of individual market coverage, and falling in those gaps. So I think there's a real need, and this is not necessarily a left versus right thing, just to create coherence for tax support across and subsidy support across all these different markets, so that they work together rather than sort of leaving people at risk of chasms when the continuity between them breaks down.
Yeah, I often say that healthcare policy people, we solve problems on paper, but oftentimes that doesn't translate to real life as easily as people who are writing policy seem to assume it does. Okay, so on that note, I wanted to have a closing question. How do we, given all these topics that we covered today and the potential environment that we have next year, how do you think that the philanthropic community can begin working towards their goals? Does everyone want to sort of have a closing remarks on how do people move the ball forward in divided government, beginning now on the issues that matter to them? Robert, do you want to start?
Sure. Ovik actually sort of already answered this question, but sort of building off of his answer regarding sort of getting involved in competition, it would be useful to have more basically information that's publicly and accessibly available to policymakers on what sorts of policies are likely to spur more competition, which ones are unlikely, because there's a lot of sort of confusion on that point on which policies have a proven track record. And so just making that clear for all the parties involved.
One area I might add to my previous answer, I would when you were zoned out, is that I think there's an opportunity, I think, or one gap I see in the landscape in terms of what philanthropy supports is there's a kind of a free pass that a lot of people who care about healthcare policy have given to nonprofit organizations. So, for example, if you're a hospital that's really acting in an economically exploitative way, but you're a nonprofit, it's kind of off the radar screen of a lot of people. The pharmaceutical industry is a for-profit industry, and everyone's really worked up about that. But very similar things go on, if not worse, in the hospital arena that don't get a lot of attention because there's this kind of assumption that if you're a nonprofit, quote unquote, what you really are is just a tax-exempt business. You're not actually a non-profit-seeking entity. But there's been this kind of free pass or lack of accountability for a lot of the practices in the hospital sector. And so I think that's an area where philanthropy can really do a lot to enhance the or shine a brighter light on the practices of hospital. That's happening to a degree. I think it's certainly happening more than it used to happen 10 years ago, 12 years ago when I started working in this space. But there's way more to do. And that's very important because unless there's more public attention directed to those unethical practices, I would argue, then we're not going to be able to change them.
Yeah, I think you've seen progress, obviously, on the billing side with a lot of the focus on surprise medical bills. I think we're still waiting to see what the full impact of that will be. But I would also argue that there should be greater sunlight on labor practices. I rent my basement to traveling nurses, and the last two of them have had their 13-week contracts cut short and just sent on their merry way in a city that's completely foreign to them, and they signed a lease and all of these things. And I can't imagine why it's legal. Like, I don't understand how you can terminate a 13-week contract after 6 weeks. But sorry, I'm getting sidetracked. I just think you're right. There are a lot of practices that deserve scrutiny and would improve the livelihood and the betterment of patients. And we should definitely be looking into those. Chris, final thoughts on how philanthropic organizations can position themselves going into next year?
Well, I think there are a lot of self-interested organizations in Washington that are short-run focused. And so the niche and the advantage of a philanthropic organization is always going to be to keep an eye on the long term and play the long game. A lot of people represent the status quo. That philanthropy is basically should represent trying to bust past that and get past that. So what kind of areas does that lead towards? I actually would like to see philanthropists kind of represent the technologies that are yet to come. So we think of telehealth, potentially the revolution that could do in so many areas. I think a lot of people, even some of us who were somewhat skeptical of telehealth, have thought, well, you this is actually pretty convenient in the pandemic. You don't have to wait around in a waiting room. You can have someone see you while you're waiting to prepare dinner or for your kids, so that sort of thing. And there are many conveniences to telehealth appointments. And then also AI, I think, is going to be very, very big in healthcare, and it is going to be very resisted by a lot of interest groups. If you think about, and there's a lot of great data coming out on this, the extent to which AI can outperform specialty physicians, physicians in many specialties. You look at oncologists, all kinds of diagnoses that are better performed by machines than humans can perform. Well, there's obviously a huge opportunity there in terms of quality of care, but there's also a cost potential benefit that is gigantic, and will be very much resisted by these specialties that are currently have their livelihoods understandably attached to these to the provision of these services. And so trying to create space, room for these new technologies to develop, but not just for them to develop, but for them to cut costs, I think is a real opportunity and a need that we're going to have. There's so much bad news and fighting to sort of hold back the tide in healthcare of costs that I think that would be an organization that is sort of needed, or at least a type of activity that's very much needed, that will be increasingly needed over the years and decades to come. So someone really trying to increase the scope for AI to improve healthcare quality, but also cut costs at the same time, and ensure that payment is aligned for doing so, and regulation obviously as well.
And I'm just going to build on that point and say that I think there's a really large role for philanthropy in that world, in that space, because oftentimes what these fights come down to is like scope of practice at the state level. And if you have two parties that have a financial interest in the outcome of the decision, it really hamstrings the movement forward, because oftentimes state legislatures, I'm thinking of telehealth, for example, and you have like telehealth disruptors, and then you have the status quo trying to stop that. And if both parties are a telehealth platform and the state medical group have a vested stake in the outcome, it's hard for state legislatures to weigh in. But if you have sort of a group that's just interested in moving the needle forward, such as the philanthropic group, I really do think that's a space where philanthropy can play a role and not just have a financial incentive to be pushing for something. So on that note, I just wanted to thank Public-Private Strategies, Niskanen, and the Rockefeller Foundation for hosting us all here for this discussion. With that, I'm going to pass it to Sam Hammond, who's the Director of Social Policy and the Niskanen Center, to give closing remarks. Sam's research focuses on the effectiveness of cash transfers in alleviating poverty and how free markets can be complemented by robust systems of social insurance. Thank you.
Thank you, Ariel, and thank you to everyone tuned in, whether live or to the recording, which we'll have available in the day or two ahead. Well, partisanship's at all-time highs. It's the belief of the Niskanen Center that the obvious divides between left and right and Republicans and Democrats hide deeper areas of potential agreement. And the burden of high healthcare costs is clearly one such area, whether it's coverage issues, high premiums and out-of-pocket costs, inequitable access to basic services. These things affect Americans across the spectrum. And that suggests there's opportunities for reform, regardless of how we think the midterms shake out. But that requires us to be forward-looking and to rethink our strategies in light of that landscape. So, as we heard today, while we're unlikely to see major system-level reforms or huge spending increases under a Republican Congress, that just means we have to get more creative. As Rob discussed, that often looks like looking at more discrete issues where there's robust consensus for incremental reforms. And some of the ideas we heard today included, attacking supply-side barriers to primary care, exploring strategies to expand the medical workforce, improving competition in pharma and the hospital sector, integrating new technologies like telehealth and AI, fixing incentives in the employer and individual marketplaces using existing subsidies in smarter ways, expanding access to key preventative medicines, or focusing on issues of maternal health care where conservatives are showing growing interest. So with this many ideas in the ether, we don't have to settle for gridlock. I just listed 7 things that the philanthropy and other stakeholders can be working on. But of course, while left and right often agree on the benefits of reform, the debate often breaks down because we disagree on the why question. Why are we doing this reform? So we need to sort of flip this order of priority and identify areas of convergence, the what, framed in ways that give each side the freedom to embrace their own why. And when it comes to finding lower cost, affordable healthcare with greater access, that's something that there are many pathways to that end, but we left and right seem to share a common priority. So to that end, I hope you can join us for our next panel on July 13th at 3 p.m., where Katie Wannenberg will be moderating a discussion on business tax policy post midterms. We'll be joined by Arnab Datta from Employ America, Alex Stopp from Institute for Progress, and Alex Maurician from Tax Foundation. So with that, I thank you for joining us and look forward to seeing you on July 13th.
Bye, everybody.